Hello and welcome to this lecture on pain management. My name's Paul and I'll be delivering the audio for each of the slides. If you see a speaker icon on the slide, if you click on that and press play, you'll get some audio to support the text that's on the slides. Okay, before you move on to the next slide, I just want you to sit for a moment and think to yourself, what is pain and how does it make you feel, and what emotions does it bring out in you? Before you move on to the next slide where we've got a definition of what pain is. Okay, so on this slide you'll see that I've actually put two different definitions. I didn't feel that either one of them covered everything, but there was bits from both that I quite liked. I quite like the first one in the fact that it says that pain is an unpleasant sensory and emotional experience. I'm sure you'll all agree that nobody really likes to be in pain, do they? And also, there's an emotional element to your pain. You have the sensory experience of your pain, but you also have an emotional response to that. The other bit in there is that it says that it's associated with actual or potential tissue damage. So pain is there as a protective mechanism. An example of this being is if you touch something hot, it hurts and you withdraw. So if you didn't have that response, you would just keep your hand on something hot and therefore you would get much worse damage to the tissues. So by feeling it and withdrawing protects your body. If you walk on uneven ground and twist your ankle, again, it stops you causing further damage, uh, because you feel it and you have a response to it and move away from the thing that's causing you potential harm. So in the second one, it says an unpleasant sensation that can range from mild localized discomfort to agony. So I quite like this because it shows that there's a scale of pain and differences in severity. You don't just have pain or you don't. You have a degree of pain or a scale of pain. So the other bit, it reinforces that there's both physical and emotional components to the pain. So the physical part is results from nerve stimulation. So we'll look at the pain nerves or the nociceptors a bit later in a bit more detail. So it says pain may be contained to a discrete area or it can be more diffuse. So at times you can, if you cut your finger, if you were to shut your eyes, you can say, right, it's the end of my index finger, and you can localize the pain. Where other times it's more diffuse. So if you've got abdominal pain, for example, like appendicitis, you can't point to an exact area where the pain is coming from. It's or an exact point. It's just an area. It hurts down on the right hand side, but you can't put a definite pinpoint position of where it is. So we'll look at the reasons behind this when we look at the different types of pain fibers. So the last bit of that second definition says that it's mediated by specific nerve fibers that carry the impulses to our brain where there is a conscious appreciation. So the conscious appreciation part of it is where the emotional component comes in. So pain itself, by definition, you have to have a conscious appreciation of it. Patients that are under anesthetic, they are unconscious, so they don't feel pain, but their body has the same physiological responses to the stimulus, so the knife or the damage to the tissues that's happening. So their heart rate will go up, their blood pressure will go up, their respiratory rate will go up. That happens exactly the same if you're conscious, but when you're conscious, you feel it and you have a conscious appreciation to that stimulus. And that is exactly what pain is the conscious appreciation of this stimulus. So this can often be modified by many factors, as it says there in the end of that second definition. So from your recovery experience, you've probably found that sometimes if you can distract people away from their pain, that has quite a marked effect because it takes away their consciousness of the pain because they're thinking about something else. If they're concentrating on the pain itself, they get very fixed on that, and it makes the emotional component of it worse and the pain of it worse. So you can modify it by many factors, distraction being one of those. So I've put this slide in here with the picture because I think if you look at this chap's face that's having the surgery there, you can see he's in absolute agony. So before we had analgesia and before we had anesthetics, it was a huge decision to go for surgery, knowing that you're going to be in absolute agony for that period of time when they're removing your leg. That was a huge decision, that was better than continuing in the state that you were. So thankfully, with modern medicines, we don't have to go through this. So before the 1800s, one of the biggest problems of surgery was knowing that you were going to have to go through this unimaginable pain during the procedure. So to try and make that better, before we had anesthetics, people would be sedated with herbs or alcohol to try and reduce the impact of this pain. So they would get you very drunk on the alcohol, almost to the point of unconsciousness, so you didn't have that conscious appreciation of the agony that you were going through. Trouble with this is it wasn't a true anesthetic. You still had feeling, but so you could never completely eliminate the horrific ordeal of the surgery that you were undergoing. In the picture here, you'll see some Arabic alchemists mixing up their potions that they used to use in these things called sophoric sponges. So what they'd do is they would get various plants that they knew had effects and would have a form of anesthetic, and they would put them into the pot, and they would bubble them away, and they would ball them up into these recipes, and then they would put them on a sponge, and the sponge would then be inserted in the patient's nose, so it was absorbed through their mucous membranes in their nose, and it would have an effect. So a typical recipe that they might have used is opium, so opium like morphine, mandrake roots, henbane, hemlock. So the last three there, they all have psychomotor effects. So by having the psychomotor effects, they wouldn't necessarily have true anesthesia, but they'd almost be in like a psychedelic dream world. So that would take them away from reality of what they were going through. So that would help manage the emotional component of their pain, and then the opium would help with the the pain receptors in there and hopefully reduce their pain and make it a better experience, but it still wouldn't be true anesthesia without feeling. Opium is probably one of the longest standing substances used in anesthesia. So it comes from the opium poppy. Its Latin name, Papaver somniferum, means poppy of the sleep. So for those of you that are fans of Game of Thrones, you'll remember from some of the episodes when they've been into battle, they'd come back and they'd be asked if they wanted milk of the poppy. Is And that is exactly what it looks like. When you get the seed husk of the poppy and you cut it, you get this milky white liquid come out, and that's the opium, and that's what gets refined and is still turned into morphine, papaverine, and codeine, as we're still using today. There's opiates, which are true, made from the opium poppy, and there's opioids, which are synthetic, so they're man-made. So things like fentanyl, alfentanil, don't come from the poppy. They're man-made versions that have the same effects as true opium-derived drugs. From fairly early on, with the primitive beginnings, very little changed in the quality of anesthesia until the end of the 18th century. So there was a rapid evolution occurred in the practice of anaesthetics, and this was due to some of the key individuals. There's some pictures there of William Morton, Sir Humphrey Davy, and James Simpson. We'll look at them on the next slide of it what influences they've had. So some of the key individuals we've got here. So Joseph Priestley in 1774, he discovered something that he referred to as dephlogisticated air. So we now know that as oxygen. What he did was he managed to take the nitrogen out of the air and was left with this dephlogisticated air, which he described in his papers that was supported combustion 5 times better than normal air. But if you think about it, we've got 21% of oxygen in normal room air. So that is, if you can take out the nitrogen, you've got then 5 times more oxygen than there is in true air, so it would support combustion for 5 times longer. He then managed to then discover dephlogisticated nitrous air, which is what we now know as nitrous oxide. So that's been around since about 1774. Humphrey Davies, he published the results of the use of nitrous oxide in the early 1800s. And he was one of the pioneers of using it, and he realized its analgesic effects. So another guy was William Morton. He first described this painless removal of a wisdom tooth from Eber Frost, and he was using ether in 1846. So the ether was dripped onto a cloth over the patient's nose and mouth, and they would breathe that in, and they would have an anaesthetic from that. So a few years later, James Simpson, he then used similar techniques, but instead of using ether, was using chloroform, and it was these two that where anaesthetics started to develop from. As you see from this slide, there's not just one type of pain, there's lots and lots of different types of pain. So if you look at the right hand side, there's pathological pain. So this is where there's pathology or damage and changes to the tissues. So neuropathic pain is an example of this, where there's damage to the nerve that gives you pain. On the other side, it's adaptive pain, so inflammation, or nociceptive pain. So nociceptive pain is where the nociceptors or pain receptors are stimulated, and we'll look at that over the next few slides. So on this slide, you can see in the diagram that nociceptive pain is pain arising from the stimulation of the nerve cells. So the nerve cells are nociceptors. So that can be from temperature, burning, acid, stimulating the nociceptors. If you prick yourself or hit yourself with a hammer, all of those things will stimulate the nociceptors that then travel up to your brain to have that emotional and conscious response to the stimulus of the nociceptors, causing this pain. As you can see from this slide, there's different types of nerve fibers that are involved in the transmission of the pain responses or stimulation of the nociceptors. So the first one is A delta fibers. So these are very fast, large, myelinated fibers. So myelinated fibers have this myelin sheath on them that acts as an insulator and also speeds up the transmission of the signals. So they're much faster. So the speed along these nerves is between 5 and 36 meters per second. So it's quite fast. And these are the ones that transmit that sharp, localized pain signals. So you can definitely pinpoint where the pain messages are coming from. So you could say it's definitely at the tip of my index finger. And with your eyes closed, you could, describe where the pain's coming from. The other fibers are C fibers. So these are much smaller and they're slower because they are not myelinated. So they don't have that myelin sheath on them. So these are the ones that give you that burning, throbbing pains or nondescript type aches. So they have a much slower speed of travel. So they're only 0.2 to 2 meters per second. So these are the ones that give you that nondescript pain that you can't pinpoint. So you've got abdominal pain, but you can't definitely point to where that pain's coming from. You've just got abdominal ache or pain. In this slide on the left hand picture, you'll notice that there's the peripheral nerve, and within the peripheral nerve, there's the different types of nerve fibers that come in. So the ones that we spoke about earlier, you can see there's the A delta fibers in the middle that are myelinated, and they're the faster fibers. And then beneath that is the smaller C fibers, and they're all coming in through the same spinal nerve root, and they all come into the back side of the spinal cord, the dorsal root it's known as. So the sensory messages come in through the dorsum of the spinal cord, and the motor messages come out of the front of the spinal cord. One thing to take note of that we'll talk about later is these A beta fibers. You can see they're even larger than the A delta fibers, and they're also myelinated. If you remember those for later on, we'll talk about those again. But again, all of these different types of fibers coming through the nerve roots at each level of the spinal cord. The picture on the right hand side shows something called the sensory dermatomes. If you see that on this chap, there's the stripes on his body, that represents the areas that are supplied by each of the separate spinal nerves. So the spinal nerves come at the left and the right hand side, and they will supply a strip of the body with the sensory information, and it shows on there where each of those levels cover.
So on the previous slide, we'd looked at how the spinal nerve roots come in and bring in the sensory information. So the next thing that we need to look at is how this sensory information gets up to our brain to be perceived as pain. Because if you remember, pain is that conscious perception of a stimulus. So if we look over here on this side, we've got the nociceptor. So the nociceptor, they were the pain nerves that are coming in. So this can come from any point within your body, and then it will come into the spinal cord through this, the dorsum of the spine. So the nociceptor is also sometimes known as the first order neuron. So it comes into the side of the spinal cord as the first order neuron, and then there's a synapse here where it goes into another neuron, and this is known as the second order neuron. So what this does is it takes it across to the other side of your spinal cord, and then at this point it enters this place called the anterior spinothalamic tract. So what the spinothalamic tract is, if we look at its name, spino, from the spine up to the thalamus. So the spinothalamic tract takes this sensory information from the second order neuron all the way up into the thalamus within the brain. And what the thalamus is it's almost like a telephone exchange center. So all of this sensory information is coming up from the spinal cord, and then it's the job of the thalamus to relay this information to the sensory cortex within the brain. And depending on where these messages are coming from, it will go to a different area within this somatosensory cortex, which we'll look at over the next couple of slides.
This picture here gives a representation of the somatosensory cortex. The thing to note on here is the size of the area that is associated with each part of the body. So if you have a look, the hands and the face are given quite a large area of the brain to process that information. This has evolved over time, where the most important areas are given the largest bit of the brain to deal with those messages and to process those. If you think to yourself that your hands and your face are often the most exposed areas, this is potentially come from sort of the primitive protection that we need our face to be very sensitive to protect our eyes and the sensations that are there, but also our hands need to be very sensitive for us to be dexterous and to have those messages coming back to ensure that we've got good dexterity. And if you compare that to the leg, for example, there's only a small area of the sensory cortex that's assigned to the leg, whereas the hand and the face have quite a huge area. We're now going to start to look at different types of pain. So the first one that we're going to look at is somatic pain. This is your sort of pinprick, stabbing, sharp pains. So these are carried through the A delta fibers from the peripheral nerves. So examples of these are superficial lacerations, superficial burns, when you have an injection, or you get abrasions like you've scuffed your knee on the floor if you fell over. So again, this type of somatic pain, you can pinpoint exactly where it is. You know whereabouts on your body that it's come from, and it's easily localized. So some of the treatments for this could be cold packs, tactile stimulation, paracetamol, simple uh, analgesics up to opiates, or local anesthetics. So local anesthetics work by stopping the pain messages traveling along the nerve fibers. Um, the stimulation of the peripheral nerves and the nociceptors is still happening, but the messages can't get to the spinal cord and then up to the brain to be interpreted as a pain message because they've been stopped by the local anesthetic. Type of pain to look at is visceral pain. So this is pain that originates from organs. So it tends to be generalized pain, and you're not able to pinpoint the exact location. So it can be an ache, pressure, sharp sort of pains. So these ones are carried by the C fibers, the smaller unmyelinated fibers, and they're much sort of deeper innervations. So examples of this type of pain is from the periosteum. So if you break a bone, you don't necessarily get a pinpoint pain where it is. Your forearm hurts without being able to necessarily localize it. So if you get muscle injuries or sort of colicky type pain, so if you're getting spasms of your bowel or your uterus, for example, you can't pinpoint exactly where it's come from. You've got this diffuse pain across your abdomen. Appendicitis, we've said about earlier, again, that's a visceral type of pain. And kidney stones, you don't get an exact pinpoint where the pain is. You get that horrible sort of pain across your flank, radiating around your back, and you can't pinpoint that. So treatments for this type of visceral pain can be anti-inflammatories, non-steroidal anti-inflammatories, opioids, spinal local anesthetics, and antispasmodic drugs can work. So if it's bowel spasms, Buscopan, for example, would help reduce the spasms and reduce the sort of visceral pain. The next type of pain we're looking at here is neuropathic pain. So neuropathic pain is caused when there's damage or adaptations happen to a nerve for a specific reason. So these can be sort of radiating pains, burning, pricking, tingling, electric shocks. They can be any sensations that you would normally receive, but actually they're happening and they're originating from the damage from the nerve. They're not originating necessarily from the peripheral nociceptors. So some examples of this could be trigeminal neuralgia, peripheral neuropathy. If people have had limb amputations, in their head they still feel like their big toe is hurting when actually their lower leg has been removed. So the nerves that were supplying the big toe have been damaged or altered in a way, and they are um, initiating these nerve signals that are interpreted as pain. So you can get herpetotic neuralgia. So if you've had shingles, you can get changes to the nerves in the area that's been affected by the shingles, and the herpes virus itself changes the nerves, and you can get this neuropathic pain caused by that. Neuropathic pain is quite hard to treat. You can't necessarily use simple analgesics to do it, and because it's the nerves that are initiating the messages, they're often treated with things like anticonvulsants or tricyclic antidepressants, or nerve blocks to try and reduce these impulses that are coming up. The anticonvulsants and tricyclics sort of calm down the nerves and change the neurotransmitters that are being produced that initiate these nerve impulses. So by using those, it suppresses the severity of the neuropathic pain.
On this slide, we're going to look at the inhibitory pain pathways. So there will be occasions where it would be bad for our bodies to be able to feel pain. So an example of this is the whole sort of fight or flight thing. If a tiger was chasing you and you scratched your leg on a rock, it would be detrimental for you to worry about your leg at this point because there's a tiger chasing you. So our bodies have these natural ways that we can inhibit our normal pain pathways so we don't feel pain at that point. So what happens is the higher brain centers decide now's a bad time to feel pain. And what happens is that neurons within the hypothalamus stimulate other neurons within this area called the periaqueductal grey matter within the brainstem. This then communicates with an area called the raphe nucleus, and that's within the medulla oblongata, again within the brainstem. So once this medulla oblongata and the raphe nucleus is stimulated, what it does is it sends inhibitory pain signals down here, down this inhibitory neuron, and it comes down through this dorsolateral tract. And what that does is then follows down and it comes to this synapse that we looked at earlier, and that was the synapse between the first order neuron and the second order neuron. So as it comes down, what it does is it releases natural endorphins, and these become, they stop the pain messages getting from the first order to the second order neuron. So the inhibitory neuron releases neuromuscular transmitters, but what they do is it switches off the vesicles that would excrete the neurotransmitters from the first order to the second order, but also it stops the receptors on the second order neuron receiving some of the pain signals that will be coming across from the nociceptor. And the interesting thing about this is actually the neurotransmitters that the inhibitory neuron is releasing are actually the same as opiates and opioids that we give our patients to fight their pain. So actually, when we're given opiate medication, what we're doing is we're tapping into our body's own inhibitory pathways. So if we can switch off the messages getting from the first order to the second order neuron, these sensory messages can no longer find their way across and back up to the thalamus within the brain and the sensory cortex. So if they can't find their way to the sensory cortex, our body can't perceive that signals as pain.
In this slide, we're looking at something called the gate theory of pain. So the gate theory of pain is where you can use a non-painful stimulus to close the gates to the painful stimulus. So if you remember from slide 14 when we looked at that peripheral nerve, in there we were looking at the A delta and the C fibers, but I mentioned in there was also these A beta fibers. So they're much larger myelinated fibers. So because they're large and myelinated, the messages that travel along those travel much faster, and they're the ones that take tactile messages to the spinal cord and then up to the brain. So the gate theory got its name by, if you think of a farm gate, if you've got a load of sheep all trying to get through the gate at the same time, only a certain number can actually get through the gate. And that's the same with the gate theory of pain. If you use the tactile stimulus that travels down the A beta fibers, that travels down much faster. And by overstimulating that, you can suppress the slower A delta fiber messages, so the pain messages also getting through the gate. So less of the pain messages get through the gate and they're overcome by the tactile messages. So when you rub your sore knee, it takes away from the fact that it's stinging because you've just fell over and taken the skin off of your knee. So by using that rubbing, you overstimulate and suppress the pain messages that come through. So this is known as the gate theory of pain. So this was first sort of described in about 1965 by Ronald Melzack and Patrick Wall. And it is where you use that mechanical stimulation of the touch fibers, the A beta fibers, to switch off the pain signals. So I'm sure, if any of you are parents, you often, if your child falls over, you tell them to rub it. But actually, what you're doing is using the gate theory of pain to help make it better for them. So this is also how a TENS machine works. So a TENS machine uses lots of stimulus to hopefully overcome some of the pain messages coming through. So that's using the same sort of theory, using a non-noxious stimulus to suppress the noxious, painful stimulus. So far we've looked at how pain messages get to our brain to be interpreted. So we're now going to start to look at, why should we manage pain? So by having persistent acute perioperative pain, it uses up a lot of our physiological reserves. If you're using your energy to fight the pain that you're going through, it uses up your physiological reserves. We only have a finite amount of reserves, and these could be used for healing, etc. So by using up the reserves can slow down healing. It may exacerbate any comorbid condition. So if you've got heart disease, for example, by having that extra strain on your heart, because pain gives you a tachycardia and a raise in blood pressure, that makes your heart work harder. And if it's already compromised, by working harder, further exacerbates the problems. So if you've got pulmonary complications, if you've got COPD or something like that, if you're in pain, if you've had abdominal surgery, for example, if you're in pain, you don't take such large, deep breaths. And if you only take small breaths, the bases of your lungs can soon collapse and get consolidation, and they might, fill up with mucus, and you end up with a chest infection. So it can make, your pulmonary complications worse. So rehabilitation and functional outcome. If you're in pain, you can't do your physio as much, or you won't do your physio as much because it hurts. An example of this being is the functional outcome after a knee replacement is physio has a large part to play in this. So if you're in pain, you won't bend it as far. And if you don't bend it as far, you'll get contraction of the soft tissues around the new knee replacement, and you'll have a reduced range of movement. Whereas if you've got good analgesia, you'll be able to push yourself harder and bend the knee further earlier and for longer. Therefore, you get less contraction and better functional outcome from that point of view. If you don't sort out acute perioperative pain or postoperative pain, it can lead to chronic pain syndromes. If you've got nerves that are being constantly stimulated from the pain, they have changes at the synapses that can cause the neurotransmitters to still be released, even though there's no pain messages coming along. So the faster you can treat and the better you manage the pain, the less chance of getting chronic pain syndromes. So another thing is increased hospital stay. Patients aren't able to be discharged from hospital if their pain is not managed. In hospital, we can use much more aggressive analgesics because we're monitoring patients better. And having uncontrolled pain is something that will prolong their stay in hospital. And last of all, but very important, is it decreases patient satisfaction. So we want our patients to be happy. We want them to have good quality care and enjoy their stay as much as possible. But if they're in pain, that's the bit that they're going to remember about their stay. And also, if they have further surgery afterwards, it's going to be in their mind that, oh, I remember last time waking up, I was in agony. or is that going to happen this time? So for any further surgeries that they're having, they'll be, extra nervous about it, and they'll have those memories of being in pain and having a poor experience. As a recovery nurse, one of our roles is to effectively manage the pain of the patient. And I think that's an essential component of care of our surgical patients and patients in recovery. If we can use all of the techniques that we're able to manage their pain as fast as possible, as well as improving their experience, it has prolonged effects. I mentioned earlier about wound healing is slowed if you're in pain. It also suppresses your immune system as well, because you're using your physiological reserves to almost fight the pain. You're not using them for your immunity, so it increases chances of wound infections and surgical site infections. From a patient comfort point of view as well, if you're in pain, that can lead to anxiety, and if we can reduce that, it accelerates the recovery time, and reduces the risk of getting these neuropathic pains and chronic pain syndromes. If we think of the perioperative journey, there's 3 phases to it, and we can use each of those phases to be able to manage pain. So we'll look at them separately over the next couple of slides, but we can use pre-medication, intraoperative pain relief, and post-operative pain relief. Medication can be used before the surgery. So the idea being that if you have preoperative administration of opiates or non-steroidal anti-inflammatory drugs, they can be working to be inhibiting the pain messages earlier on, and it gives the drugs the chance to work or have maximum effect. So if you're using non-steroidal anti-inflammatory drugs, this can reduce the inflammation caused by the initial injury to the tissue. So the damage caused by the surgical incision. If you can suppress the inflammation before it happens, that has a better effect than trying to suppress it after it's happened. So there was a study that happened looking at patients that were having day case laparoscopic cholecystectomies, and what they were doing was giving the patients preoperative oxycodone. So they were giving them an oral dose of preoperative oxycodone, and it was having a much better effect than giving them the same dose intravenously during the surgery. When they looked at the results, the patients were having lower pain scores, they needed less rescue analgesia in recovery, and their total time before discharge was actually reduced. So it's kind of the idea of prevention's better than cure. Intraoperative analgesia is the next stage, so during the surgery. So we need to provide analgesia that will give pain relief during the knife to skin phase. So to have a balanced anesthetic, there's something called the triad of anesthesia, and the 3 bits of that are the narcosis, so the sleepiness of the anesthetic, muscle relaxation, and analgesia. And without all of those 3, it doesn't become a stable, balanced anesthetic. So to get over the knife to skin bit, the initial stimulus, that's when the first physiological response is going to be. We use fast acting, short acting opiates like fentanyl or alfentanil, so they will have their maximum effect much faster than some of the longer term opiates, and they will cover the knife to skin. If you've got a longer surgery, their effects is going to start to wear off, so you might have to use longer term intraoperative analgesia, such as longer term opiates, so morphine, diamorphine, oxycodone, which have a much longer effect. Also, IV paracetamol is very good as a supplementary analgesic, because it's managing the pain using a different pathway or a different method. So by using different types of sort of polypharmacy, you manage the pain in a different way. Remifentanil is a very good opioid. but it is very short acting. It's very potent, but it has a very short half-life of about 3 minutes. So you have to run it as an infusion. This is good for surgeries that are particularly stimulating during the surgery, but not so much afterwards. You can also use local anesthetic infiltration. So whether that be local anesthetic infiltration in a particular area or a regional nerve block. And by doing that, you stop the pain messages traveling along the nerve and stop them getting to the spinal cord and up to the brain. So then you don't get the physiological response, or once they've awoken, you don't get the conscious uh, perception of the pain, because the pain messages are no longer getting to the brain to be perceived as pain. So if we don't manage intraoperative pain, you'll have the same physiological responses to the pain. Strictly speaking, they're not responses to pain, they're responses to the stimulus, because our patients are unconscious when they're anaesthetised, so they don't have that conscious perception of the pain or to the stimulus. So physiological pain responses still happen to an anaesthetised patient. So you'll get tachypnea, tachycardia, hypertension, sweating. You might have reflex movements if they're not paralysed. So all of these things can have detrimental effects. So they increase oxygen demand for one, but also if your heart is working harder because they're hypertensive and tachycardic, it increases the risk of MI, particularly if they've got previous cardiac issues. For intraoperative analgesia, as well as using opiates and non-steroidals and things like that, you can use neuroaxial anesthesia. So this means when local anesthetic is placed around the nerves of the central nervous system. So examples of this are spinal anesthetics and epidural anesthesia. They're all neuroaxial anesthesia, so it stops the pain messages traveling up the spinal cord and getting to the brain to have a response. A nerve block is a technique where local anesthetic is applied around a nerve or a group of nerves that makes an area of the body numb. So, for example, a brachial plexus block stops the pain messages traveling up the peripheral nerves through the brachial plexus. And if it can't get past that point, it can't get to the spinal cord and then the brain to be perceived as pain messages. So these are often used for limb surgeries, so knee replacement, shoulder surgery, hand or foot procedures. They can all be made numb so the messages don't get through, and this reduces the need for opiates, therefore reducing the side effects from the opiates. And patients tend to get really good analgesia if the block is working well. Here are some examples of peripheral nerve blocks. So upper limb blocks, you might use brachial plexus blocks. So they could be axillary approach or a supraclavicular, so above the clavicle, infraclavicular, below the clavicle. They're all examples of brachial plexus blocks. If you're doing surgery on the lower limb, you might use femoral or sciatic blocks, or if it's just foot surgery, you might numb the nerves at the level of the ankle and prevent them coming up and being interpreted as pain. If you're having abdominal surgery, you could use techniques such as a transverse abdominal plane block or TAP block, and this gets the nerve roots as they come round through this transverse abdominis plane, and the local anesthetic bathes the nerves as they travel across through this plane and then numbs the abdomen for the surgery. If you're doing thoracic surgery, you can use intercostal nerve blocks or interpleural nerve blocks. Interpleural nerve blocks are where you use like an epidural needle or TUI needle, it's called, and you place that needle between the two layers of the pleura, between the visceral pleura and the parietal pleura, and you put local anesthetic there, and it travels round to the back and bathes the nerve roots as they come round and supply the anterior part of the chest. So when you're doing regional nerve blocks, ultrasound imaging is often used. And they say that this increases safety, and in the right hands, it increases accuracy and improves success. Some of the benefits of using regional techniques as opposed to higher dose opiates is that it gives a much faster recovery time because you don't have that hangover effect from the opioids, or you don't have the other side effects, so less nausea, for example. If you've got a well working nerve block, the pain after surgery is dramatically reduced, and that allows you to increase your mobility afterwards, and it allows you to do better physio, for example, and keep the limb moving afterwards. You don't have as many side effects from the opiates, so you don't have that drowsiness, the stomach upset, the constipation, the dizziness. So by using less opiates, you get all of those advantages if you get a good working nerve block. Spinals and epidurals are examples of neuroaxial anesthesia. So it's where you're putting local anesthetic around, either with an epidural, you're bathing the nerve roots as they come out at each level from the spinal cord. You're bathing those in local anesthetic, therefore stopping the pain messages getting to the spinal cord. And with a spinal anesthetic, you're putting local anesthetic into the cerebral spinal fluid, or the CSF, and it bathes the spinal cord in local anesthetic and stops the pain messages traveling up the spinal cord, both of which will stop the pain messages getting to the brain to be interpreted as painful messages. So, with post-operative pain relief in recovery, I think one of our primary goals as recovery room staff is to make the patient as comfortable as quick as possible. This has an effect on all the things that we've discussed earlier. So, to do that, you must make an assessment of the patient's pain. And pain is what the patient says it is, and is very subjective. One person's mild pain could be someone else's agony, and patients will perceive the same stimulus of the pain very differently. And we have to treat the patients in the way that, if they say they're in pain, we have to treat them as though they're in pain. So one of our challenges is to be able to assess all relevant factors without imposing any sort of personal biases in there. On this slide, I've included some sort of common misconceptions about pain. So have a think to yourself, what do you think about these following statements? So the recovery practitioner is the best judgment of the patient's pain. Hopefully you've said that that's false. So as a recovery practitioner, it would be unethical for us not to treat a patient if they say that they're in pain. So if they say they're in pain, we have to treat them as though they're in pain. That leads on to the next one. So a person in pain will always have obvious signs such as moaning or abnormal vital signs. So do you think this is true or false? So yeah, again, this one is false too. So if you think of the stiff upper lip, of particularly with the elderly population, they're very stoical often, and they won't verbalize their pain. You quite often get that, I'll be all right. And actually, they don't like to admit they're in pain because they feel that that's a weakness or they're bothering you. So they might not be moaning about the pain. And also, from a vital sign point of view, normally, if we're in pain, we get tachycardia and hypertensive. But if you're on beta blockers for a heart disease or antihypertensive, they're going to suppress the physiological response to the pain. So you may not see a tachycardia or hypertension. So the next one down, pain is a normal part of aging. Again, it's not a normal part of aging. Yes, they're more likely to have conditions like osteoarthritis that lead to pain, but actually, is it right that they're in pain? They may have conditions that mean that they have an increased risk of pain, but we should still be managing the pain. Just because they're old, they shouldn't be left in pain. They should be managed appropriately. So the last one on here, addiction is common when opiate medications are prescribed. So addiction isn't that common. You need to have long-term use of opiates to become addicted. And there's two different types of addiction. There's the psychological addiction, where you like the feeling that it gives and you get addicted to that. Or there's the physiological addiction. So if you're on long term opiates, our bodies get used to that. So when you don't have them, you have withdrawal symptoms of that, but that takes a while for that to happen. So some other post-operative pain relief techniques could be, oral pain medicines, so non-steroidal anti-inflammatory drugs such as naproxen, diclofenac, those kind of things, paracetamol, tramadol, codeine, Oromorph. They can all be used, and can be effective. Sometimes, if the pain is more severe, we might need to use sort of opiate regimes. So most recoveries will have, morphine or fentanyl or oxycodone and sometimes diamorphine protocols that you follow, um, and you have, recovery morphine written up, and you follow your morphine protocol for its administration. Other things can be patient-controlled analgesia. So we'll look at that on the next slide in a bit more detail, but sometimes morphine, fentanyl, and oxycodone are used as part of the PCAs. So we've mentioned earlier about neuroaxial anesthesia. So spinals are generally a one-shot injection, whereas epidurals you can leave a catheter in situ and then you can run the local anaesthetic over a period of time. Generally, it can be up to sort of 72 hours, so that can give a prolonged pain relief afterwards for bigger surgeries. So patient-controlled analgesia is quite a good method for post-operative analgesia. It allows the patient to be in control, and it allows the patient to reach their own minimum effective analgesic concentration, it's known as. So it allows them to decide if they're in pain and if they need a dose of morphine, for example. And by having the pump, it increases the safety element to it, because there's a lockout period set on the pump, generally 5 minutes. And then even if they keep pressing the button, they'll only get a dose at a maximum of every 5 minutes. This increases the safety element because the sort of thinking being that before they get to the point of having severe side effects like respiratory depression, they'd fall asleep, so they won't press the button, therefore can't give themselves more morphine. Whereas if you had a constant infusion of morphine, that would keep going regardless of whether the patients become unconscious or not. Whereas with a PCA, they have control, so it gives them that ownership and be able to manage their own pain, but they also are able to give themselves enough morphine to manage their pain relief accordingly. So when using opioids or an opiate medication, it's important to be aware of the side effects that they might cause. So the most concerning, I suppose, is respiratory depression. A little bit of morphine will slow the respiratory rate, but if you give too much of it, you can stop the patient's breathing. So it's really important that we monitor our patients closely and observe for any signs of respiratory depression. Hopefully, if we're using our morphine protocols in recovery, we avoid getting to the point of respiratory depression that's severe. But it can happen. It's really important to be mindful of that when administering intravenous opiates. The other most common side effect can be nausea and vomiting. So lots of patients will get nausea from opiates. So if we can use other techniques such as regional blocks and things, it can reduce the amount of opiates that we give and therefore reduce the side effects of the nausea and vomiting. So opiates also have a sedative effect, so again we need to be mindful of that because patients can lose their airway if they become over sedated. Another side effect is that opiates can make patients itch, and that can often drive them madder than the pain itself, and the itching can be a problem. So the itching is caused by histamine release. Opiates are quite allergenic, I suppose, and you do get some histamine release with them, and that's what causes the itching. So patients can often get constipation, so it slows down your gut motility and can lead to ileus. So if you're on long-term opiates, you can get bowel ileus, where the peristalsis within the bowel stops, and also urinary retention can be a problem. So it's really important to monitor the patient's urine output when they're on opiates, particularly if they're not catheterized. So on this slide, there's an example of a pain assessment tool. As I mentioned at the beginning with the definitions, there's a pain scale. It's not no pain, in pain. There's a degree leading from mild discomfort to absolute agony. And as recovery practitioners, it's always useful if we have used these pain assessment tools. So they can be scales of numbers. I quite like the 0 to 10. Some trusts will use 0 to 5 or 0 to 3. But if you use 0 to 10, it's quite easy to then be able to show that the patient has an improvement. If you say to them, "What's your pain score?" and they go, "Oh, it's 10, I'm in agony," you give them something. If it then goes to 9, you can say, "Oh, good, we've got an improvement with your pain. It's gone from 10 to 9, so we're going in the right direction." Whereas if you've only got 0 to 3, it takes quite a long time to get from 3 to 2. So you can't use those same sort of psychological techniques to manage the emotional side of the pain. So by having that 0 to 10, it gives you a much better range, and then you can use that as a psychological technique to help manage the patient's pain, and you can show that their pain is getting better and you are getting on top of it and you are managing it appropriately, and it gives them a positive out of the fact that they're in pain. When you're using pain assessment tools with children, they won't necessarily understand the 0 to 10 pain score, so you can ask them to point to the smiley faces or the sad faces depending on how they're feeling, and that's a way of assessing their pain if they don't understand the 0 to 10. So you can use that with children or patients that have got communication difficulties or disabilities. It works as another technique from that point of view.